Hello and welcome to the Weatherford College EMS podcast. This is going to be episode number 8, where education meets experience and textbooks meet the street. I'm your host, Tyler Holland, also known as the NIH Man, joined by our resident historian, Adam Parish, and our been there, done that career guru, Samantha Grimsley. Today we're kicking it off with a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little bit of fun with it. We are talking about sedatives. Yeah.
I think one of the things we have to remember is not all sedatives are the same, just like not all analgesics that we were just talking about are the same. And they have to go hand in hand. They're often confused with one another. I think a lot of people sometimes think, oh, I'm giving a sedative, it's taking care of the pain properties.
Sure.
And vice versa. And clinically, while they tend to overlap, they have different objectives and different seats at the table. And so while analgesia, the goal is to relieve pain, sedation is, trying to calm or depress the central nervous system. And so I'm probably going to take this from Adam. He was talking a lot about the receptors when we were talking about pain management, but one of the most important concepts is just understanding how do sedatives work from the neurotransmitters, talking about glutamate and GABA. And glutamate is a major acceleratory neurotransmitter in that central nervous system, and GABA is the major inhibitory neurotransmitter, and they work together. Glutamate acts as the brain's gas pedal, while GABA would be the brakes of the brain. So most sedatives work by pushing harder on the brakes, which is going to stimulate that GABA, or taking their foot off the gas pedal, which is going to be blocking the glutamate. And while several receptors in the excitatory system, wow, I can't even say that word, excitatory, I'm so excited, stimulate glutamate, the most common one is manipulated by sedatives is the NMDA.
Love it.
So when we talk about things like ketamine, that's going to inhibit glutamate, which we said is the brain's gas pedal, and it's going to block I can't even say it, NMDA.
NMDA.
Yep, that word. That's the one. And then the other common one we give is benzos, and those are going to inhibit your channels to open longer, while barbiturates, which again more in the hospital setting, they're going to inhibit channels to be open more frequently. And then we've got etomidate, which is kind of like rogue on its own, and I almost forgot about it in this medication class, but it requires less GABA to activate those receptors. So when we're talking about, how we're putting the gas pedal on one side of the brain, we're putting the brakes on the other side, and we're blocking this and blocking that. Nonetheless, let's talk about it. Let's just jump right in with, go alphabetical order. Let's go diazepam.
Yes.
It's a benzo.
It's a benzo. It's, diazepam was first marketed in the United States in 1963 as a fast-acting, long-lasting benzodiazepine that was initially going to be used to treat anxiety and alcohol detox. Through the use of this, obviously, they found that this has other applications, that it can work well with other things. Now, diazepam is also marketed as Valium. Now, I know a lot of people struggle with all the PAMs and all this.
Oh, I have a fun one. You want to hear it?
I do.
Diazepam is a D in the alphabet, right? Mm-hmm. Well, Valium has A for the next letter after V, because Versed is the same thing. It starts with a V, right? So A comes before E and D comes before M. So I always correlated the D and the A together and then the M and the E together. Me versus duh.
Me versus duh.
Yeah, you confused me even more with that one.
I'm sorry. I look at the alphabet, and that's how I'm rolling it. The D in the alphabet and the A in Valium versus the E in Versed and the M in midazolam.
We'll let you guys decide if that helped or not.
Never did me wrong.
Let us know.
Stay tuned.
Yeah, so diazepam has been around, or Valium has been around for a long time. It's been used for multiple things, more than just sedation, and we'll get to some of that a little bit later. But really, these things, the drugs that we're about to really get into and discuss, they have their pluses and minuses, and again, that's why we do this, right?
Mm-hmm.
This is one of the things that we really want y'all to have a better idea of before y'all start, passing out these drugs on your own, right? One of the cool things about Valium is, again, I kind of touched on it. It's it can be used for many different things. Some of the things that we have to be watching out for, though, a little bit more so than some of the other ones, is it sometimes will cause hemodynamic instability.
Ooh, I love that word, especially as we were coming out of cardiology. We talk about stable versus unstable. Yeah, so I think one of the things we're recognizing, and we talk about medical directors kind of getting into the know, is diazepam is not heavily seen on the trucks anymore as much as we see like midazolam or lorazepam, and even lorazepam I feel like is kind of coming off the trucks as much too, and we'll talk about that later. But I think it's due to the fact that there's more versatility out there and ease of use versus this one. I mean, you said it, and I've seen it, diazepam is more useful in these situations, but then also I've seen that it's not really ideal in acute behavioral, but it also says that it's because it's got a slower onset, less predictable outcomes, but then you said quite the opposite. So which one is it?
Yeah, so, I mean, as I'm looking at, I'm going to steal Tyler's favorite website.
Go ahead.
The
Go for it.
here.
Everybody steal it, please.
Yeah. One of the big problems is, how long does it last? It typically lasts for a lot longer than some of the other drugs. Therefore, it essentially will stack up on itself, right?
Mm-hmm.
And so as this starts to depress your CNS and everything else, it just can continue. And something you said in a previous pod, the one before this, is when you administer a drug like this, you got to let it cook.
Yep.
Right? You got to let it circulate. You got to see what it's going to do. You can't just give it and say, how about now? And then give some more. And how about now? And then give some more. And how about now? Right? Because by that point now you've overdosed somebody.
Yep.
You've got to let this thing work. Right? I've said it a couple of times. Our bodies work on the speed of biology. That being said, Valium being that kind of that older school drug, and as versatile as it is, really became a very popular thing to have. And it was also, and unfortunately we have to consider these things too, it was cheap.
Yep.
Right? It was cheap and it was available.
Mm-hmm.
And it treated a lot of things. And when it came down to just somebody making a decision as to, like, should we carry this? What should we use? Well, hey, guess what? It can help treat alcoholics that are in DTs. It can treat anxiety. It can help with muscle spasms.
Yep.
It can help, with sedation. Some seizures. It can help with. There's some places that'll do like procedural sedation. It can treat all kinds of things with one drug. The problem, again, hemodynamic instability. Okay? Now this drug, it typically will relax the patient, it'll make them feel a lot better, and then they stop breathing.
Yep. They were feeling great till then.
That's right. And the other problem is this is not an opiate. Right?
Nope.
This
Benzo.
this is not something that we just pull the Narcan out and fix.
Nope.
Mm-hmm.
You have to go with Fomazanil.
You
Or
have to
or
go.
Romazicon. I like saying Romazicon.
I like Romazicon too.
Mm-hmm.
But and part of the problem with that is not a lot of places carry Romazicon outside of the
No, the
hospitals
first time I
anymore.
heard about it, I was on an aircraft, and it was because the hospital had overdosed a patient on a benzo, and was why we were giving it. But you make a good point there. The other aspect of it is when you sit there, and I even looked up, sedation and pre-hospital care and what to go with and that, there's so many different ways that they're going about how to choose. You can go the SAT scores, you can go the RAS scores, and nobody's got time for that.
No.
Nobody has it, so you have to be able to think, okay, what's going to do the job of what I'm after, right? And we talked about that in analgesic, but looking at what's the onset versus what's the half-life versus how long is it going to be in the system until it's metabolized, it really comes down to that. And then you have to think about some of the other properties. Some of these medications are technically meant to be refrigerated. Like lorazepam, it only has a 2-week shelf life technically in the ambulance setting because it's supposed to be in a refrigerated receptacle.
Absolutely.
And I believe, if I'm not wrong, diazepam and midazolam are also like 30 to 60 days as well. They don't have a very long shelf life either because our environments are fluctuating constantly and nobody has a cooler to leave on an ambulance. And if they do, good luck keeping your sandwiches out of it.
I don't know anything
good
about
point. Good point.
There may or may not be labels on the ambulances because of that. But I mean, I feel like midazolam is one of the more common ones that I was using when I was in the field setting. And I feel like I used it a lot more when I was, coming off of a procedural sedation, like RSIing a patient, and you're looking for that post-sedation management. What are you going to go with? And it used to always be, okay, I'm going to give, and I would time it with my fentanyl. I'll give 50 micrograms of fentanyl and 2.5 milligrams of Versed. And then if I needed to increase, because maybe they were burning through the medication a little bit faster because the duration was almost identical with one another, as well as the onset, giving that fentanyl and giving that Versed, then it was like, okay, then I will go 5 milligrams of Versed and 100 mics of fentanyl and see if we can play with it that way. Now, again, if you have a patient who's maybe on like cocaine or some kind of illicit drug, they're going to burn through that stuff a lot faster. So you're going to have to start thinking about, okay, why am I burning through my drugs so much faster than I am? Because realistically, these should be holding on for at least 15 minutes, maybe 30 if you're lucky. But the biggest thing is looking at their hemodynamic status as you're giving the medication. You should, when it's starting to wear off, especially if you're RSIing somebody or doing some kind of procedural sedation, if you're starting to see that heart rate climb, watch what happens next. Because if you're waiting and waiting and waiting and waiting and you're like, oh, I got 15 more minutes, but that patient's blood pressure changed and that heart rate changed, especially if the heart rate goes from like 90 up to 110 out of nowhere, you're behind the curve already. And I'm sorry, but don't put a tube down my throat, especially if you're giving me a paralytic that's long acting and then not give me anything not to remember it afterwards.
Yep.
Because I think a lot of people forget that, especially in post RSI, is, well, I paralyzed them. They're not bucking the tube. That's great. They still got to take care of the aftermath, and it's a very painful procedure.
Yeah, it is.
I don't want to remember it, nor do I want to feel it.
Yeah, well, they physically can't buck the tube.
I mean, they can't, but they're hyper-focusedly aware of what's going on. It's like, think about what you're saying in front of your patients, because they can hear everything that's happening. Whether or not they can do anything about it, that's a different case. So...
Yeah, and you bring up midazolam. A couple of things to think about, too, is how are these things utilized in the body? Right? Like, are they being utilized by the liver? Are they being utilized by the kidneys? And then to take that a step further, anybody that has any of those issues, right? All you're going to do, and kind of like I had mentioned earlier about letting that medication cook, let it take effect on the patient. If you have a patient that is not able to metabolize these things very quickly, it's just going to sit there.
Yep.
And so don't be, you don't necessarily have to say, oh, well, I can't use this in that patient population. But what you need to do is you need to have an understanding that it's going to have a much longer effect on that patient. So understanding these things is very, very important.
Yeah, lorazepam, we'll talk about it here in a little bit, but just, thinking back to one of the questions I always love to ask students is, well, how do you determine which PAM to go with, longevity-wise? And sometimes the trick that I'm out looking for is lorazepam is the longest PAM that's going to stay in their system. Midazolam is going to be in there for about 2 to 6 hours. Diazepam, 50 to 60 minutes, not very long. But when you look at lorazepam, 6 to 8 hours. It's a long time. And so when we get into anticonvulsants, that's kind of my go-to, because you're less likely to see a breakthrough in convulsions. But again, that's because these drugs do so many different principles, and that's why we're going to talk about them continuously as we move through into anticonvulsants later, because we're in neuro, right? But nonetheless, what do you guys like using in the field setting? What's your go-to as far as a benzo?
Well, when I worked in the field, the really only choice we had was midazolam Versed. And I've not had any big complaints about using midazolam. And honestly, I see a lot of benzos used in the hospital now. And it really, I feel like, comes down to the physician's preference.
Yeah.
Like, what does he have he or she have the best reactions with? And they usually go with that. And I still see midazolam kind of coming out on top in most cases. And I think it's just the popular kid on the block.
Yeah, it can be used in so many different forms, from IV to IM to IN to IO. And so because of that, it's rapid onset. But, the fact of the matter is, when you need it, you got it kind of thing. Now, again, going back to what we were talking about earlier about analgesics, like, make sure you do get your IV established a case, because we know a side effect of this is hypotension. Mm-hmm. And as a result of that, also, so is respiratory depression. So you don't want to be fighting to be trying to get an IV and also bagging your patient, and all things considered. So we always talk about being proactive and not reactive when you're giving these medications, even like your opioids and things of that sort, but especially with your benzos. Make sure you have your airway ready, in case something happens. It's like putting the pads on the patient that's having the MI. You don't know that they're going to go into cardiac arrest, but you really hope they don't. But if they do, you're ready for it in case you got a defib right away, right? And so it's having that, all right, I'm going to pull my BVM out and I'm going to set it on this counter over here. I'm going to size them for the OPA. I'm going to size them for an MPA just in case. And being ready in case something were to happen as a result of it. And then checking and monitoring your patient consistently. Anytime you're giving one of these medications, you've got to be reassessing those patients. And it's not waiting the 15 minutes. It is. Yeah. I have a rule of thumb. If I'm giving a medication, within 5 minutes of that medication being given, I'm getting another blood pressure. Maybe that's the nitroglycerin mindset of like, got to keep giving this, then I got to keep getting a blood pressure. Just do that with all my medications now.
Yeah. And, we got to remember it's an induction agent. We use it to prepare for intubation and all that. So if you're going to give it for any reason, you should be prepared for that case where you might have to take an airway.
Yeah. You brought up an interesting factor earlier about Valium and being an anti-anxiety drug. Do we need to start considering some of the medications that may be in the home setting, like Xanax or any other kind of anti-anxiety medications that patients might be on, as well as, even in our geriatric patients, they're on a lot of pain management. Maybe not morphine specific, but could be, some kind of hydromorphine or even gabapentin or things of that sort. How does that play into effect with all these, especially since we were talking about GABAs and glutamate? Yeah,
so a lot of those other drugs, like Xanax, is a really popular one. Unfortunately, obviously, it's a terrible drug. But all that being said, we're not talking about that today. But mixing all those things, you need to be made aware that these are not the only CNS depressants that you're going to find. That other people are going to take those things, and when we give these other drugs, they're going to compound. And when they compound those effects, then they have the potential for, having
synergistic effects.
Well, yeah, and wide ranging as well. Mm-hmm. Right? So we can have things because we're giving this benzo, we're affecting the GABA. They may be taking something that's affecting their NMDA. Mm-hmm. And we start talking about altering all of these chemical triggers and neurotransmitters and different things. You need to be very prepared when you start reaching for this stuff.
Yeah.
You need to already kind of have an idea. And this is again why we continue to push the narrative of get your patient's history, do a good assessment, Look around the room.
Be observant.
Look for those other bottles. You know, if you have that firefighter standing in the corner that's not doing anything, tell him, go find anything with a pill in it and bring it to me.
Or empty bottles.
Absolutely. Yeah, empty bottles too, especially if you're thinking that this, potential overdose or whatever. Or even if the patient will tell you, hey, I took an extra pain pill because today was hurting really bad or whatever. Well, you need to keep that in the back of your mind when you start reaching for these kinds of drugs. That said, you were asking, what's your preference between all these things? I know Ativan has become a big user in the pre-hospital setting because it's powerful, it works well, and it works for a long time. But midazolam, I think it needs to be said that it's also a dissociative.
Yeah.
Okay, and sometimes that dissociative factor is fantastic, much like we talked about ketamine, right? I know that in the pediatric setting, a lot of times before they put tubes in ears or anything like that, they'll give them a little squirt up their nose of a little bit of IN midazolam there.
Yep.
Yeah.
Because then they get a little weird. They actually get really funny.
I've got a video of my son on some of it playing with the pulse ox cord like he's roping a cow.
Absolutely. And my own children, went through that as well, and it was, it was good times had by all. But they do that so that they get a little silly and they don't remember.
Yeah.
Right? And for that procedural sedation kind of thing, where that's something that you're kind of going for. And in that case too, a lot of times, especially when you have that psychiatric patient that you're trying to sedate, that's kind of where I go. That's a majority of the time. That's where I'm pulling that specific drug out as my first go-to. Right? We need to be careful with them because we have to understand that those patients have a shifting pH. Okay, I've already told y'all all about pH, and I'm happy to tell you again. But let me tell you this: they're already insanely acidotic.
Yeah.
Okay, it's crazy how acidotic these patients will become. And one of the really nice things about midazolam, specifically, is we actually kind of want all of that stuff to calm down. We want that heart rate to come down. We want that blood pressure to come down a little bit, right? One of the big problems that they're having this shifting acidosis is also that they're probably hot.
Yeah.
Physically hot. Their temperature will be elevated. And in those patients, that's exactly what we're looking for. Ativan is fantastic for that. But midazolam has a much more profound effect on those things.
Yeah.
And this is one of the reasons why a lot of times when you come across that psychiatric patient that you just have to walk up, give them a dose of something, a lot of people, and myself included, reach for the midazolam first.
Mm-hmm. And we were talking about on the last podcast about fentanyl and how it's becoming a lot more common, and midazolam being a lot more common on the ambulance side as well. They also synergize very well together.
Yes.
So whenever you have that patient that you need to keep sedated for a vent or what have you, that combination right there is going to really help to keep your patient in the level of conscious that you desire. And not only that, but it's going to be helping with the pain as well, associated, like we were saying, with intubation, how it is incredibly painful for the patient.
Yeah, so those kind of combinations of medications really help during those painful kind of situations where you really don't want them to remember a whole lot. Mm-hmm. There's even some places that will allow you to do some of those things and like try to put a shoulder in place or something like that, right? And again, and I'll keep going to it with those dissociatives like midazolam. They have looked into ongoing, looking at like post traumatic stress from whatever the injury or event is, And they've found a whole lot of benefit from, giving those kinds of medications, the ketamines and the midazolams, those dissociatives, not only as, for pain or sedation, but it really helps when that patient is dissociated. They don't remember anything until they wake up at the hospital.
And it's all done with.
Yeah.
Yeah, even like when we're talking about, in cardiovascular, we're talking about the tachydysrhythmias and the bradydysrhythmias and treatment of an unstable patient. And if you notice, the first thing it says we're going to cardioverted pace, it says consider a sedative. It doesn't mean stop and give the sedative, because we know that for them to be getting paced or cardioverted, they're probably hypotensive, which means then we're going to have to turn to ketamine over, one of our benzos. And so in that sense, do we have that time? Or maybe we fix the problem and that will fix the blood pressure and we don't need to give anything for it. And yes, we will explain to them that this is going to be a very painful procedure. And if you notice, we're giving a sedative, not a pain management for those things. And so that's the other end of the spectrum when we're talking about procedural sedations. But, interestingly enough, when we look at a benzo and then compare it to an opioid overdose, we were talking about, Romazicon earlier. Mm-hmm. What happens in the field setting when you don't know? You get to that patient, maybe they're a little agitated or they've OD'd on something you just don't know. I mean, I think we have it all built in our heads that if it's a narcotic overdose, we're looking for the respiratory depression. We're looking for the pinpoint pupils and the altered mental status, the pale, cool diaphoretic. But when you think about a benzo overdose, it's not much different except for one thing, and that's the pupils. The pupils are going to be different. Mydrosis is what we call them, or dilated pupils, because we know a benzo is a sympathomimetic. So we're mimicking the sympathetic nervous system, and we know that in the sympathetic nervous system, our pupils get dilated so we can see everything and have better vision. So if you're going to go look at a patient and try to figure out, well, what did they overdose on, or what's going on with my patient, and having to decide or what you need to do or how to treat, there's your key. If you've got dilated pupils and a respiratory depression and all things that, you're dealing with the other end of the spectrum, not that. And I know there's some old medical directors like, just give Narcan because there's no side effects. You just give all that you want. They're going to be side effects. Just you don't going to like them when you have them, right? But one of the things we haven't talked about when it comes to sedatives is ketamine. I mean, we talked about it as an analgesic property. We've talked about it in other podcasts. But nonetheless, ketamine has a seat at the table when it comes to a sedative. And it is one of the more commonly used now, especially when we're talking about RSI procedures and DSI procedures and things of that sort. But remembering that it's got a different dose, just like we were talking about in analgesia. You got to know what your dose is. And underdosing for sedation cannot be good for the patient. It's going to take you longer to perform what you need to perform when you now have to chase your tail because you did not give enough. You also don't want to give so much that you take away that threshold either. So it's kind of that catch-22 in that sense. What's y'all's take on this?
I love ketamine.
Everybody's
favorite. And that's for a reason, right?
Don't give it to me.
Every time we so far almost all of our of our podcasts up to now, we have said something about ketamine, and this one is not going to be any different. Ketamine is so widely able to be used for many different things, and a lot of that is dose-based, right? We talked about in the previous podcast about using it for pain, right? It has its own dose. It could be anywhere from 0.1 milligrams per kilo to 0.3 milligrams per kilo in your adult patients. But wait, there's more. You can also use it for sedation. You can use it for your agitated
2
patients.
2 milligrams per kilogram.
Absolutely.
For RSIing.
You can, and I've even heard of more than that in some cases. I've heard, there's you before you put a tube in, when you have somebody in a state of excited delirium, if respiratory issues, you've even got it as an inhalant now too. Absolutely. Does this drug have no limit limits?
I mean, it does when you start thinking about the fact that it can cause damage. Like, I know we talked about the debunking myth of a traumatic brain injury, but on the other end of the spectrum, if we have a patient, again, we were talking about earlier, giving a sedative for maybe a cardiovascular event. However, if we give ketamine, it can cause an increase to heart rate and blood pressure due to that sympathetic nervous system being stimulated. So if our cardiac event is maybe because we have some kind of MI going on or something that's outside of our control, and we give this sedative, and then we go to pacing or we go to cardioverting, depending on the situation at hand, it can lead to a higher demand of myocardial oxygen.
Yeah.
And that's not good in those cardiovascular patients. So that's why we say the words, we are going to consider. Sometimes it's risk versus reward or vice versa, depending on what's going on. But nonetheless, I mean, nitrous oxide is another one of those things they use in the hospital setting, but we don't see it on an ambulance quite yet, but it is another form of a sedative.
It's big in Europe. It's really big in Europe.
Did you know if you are taking some kind of anxiety medication or even a serotonin, an SSRI, and you give nitrous oxide, it will have no effect on them?
That's interesting.
Yeah. I've seen it in patients where they're on an SSRI and they're like, I'm not feeling anything. And then they go to ask, and they finally take a medical history on the patient. They're like, well, there's the problem.
Yeah.
And that's just because of what's going on chemically in the brain and how it's crossing that blood-brain barrier. So that's why we have to know the patho behind these drugs.
Yeah, and I'm actually looking right now. It reminded me of, despite my previous statement, there are some issues. There can be lots of issues with ketamine. So I just really like it. So it was. You all need to understand it was said in jest.
Yes.
Sure.
This said, and to prove my point, I'm looking at an article right now. This was in 22 or 23 when this happened. Oh, actually, I'm sorry, 2019 when this happened in Aurora, Colorado. Some paramedics.
With that town.
Yeah, I don't know. There's
lots of bad things that happen in Aurora.
Yeah, hi Paul. So there's this case, and it became a huge thing because in 2019 ketamine was catching on because it was. Where I was working in 2019, we were going big and bold with high doses of ketamine for several different things, and so anyway, so this became a big issue, and what happened was you had a person that was in a state of what they described as excited delirium. So they were having some kind of psychological issue, and they could not be reasoned with. And so they pulled up, the paramedics arrived, and they pulled up 500 milligrams of ketamine and basically walked over to him and injected all 500 milligrams of ketamine into this guy's, either shoulder or leg or something, injected this guy, IM, and then left. Walked back away, said it's not safe, we can't fight this guy, we don't know what he's on or what's going on with this person. And then... surprise, he died. He was, at that point, he was restrained. He was put in an improper position in the ambulance. He was handcuffed behind his back. He was placed prone. He was hog-tied even, so that means they took his ankles and tied him together, and then tied all that together and threw him on there and basically said, okay, well, he's sedated. They dealt with a few other things. They came back and found him not breathing.
Mm-hmm.
So knowing this, those two paramedics are in prison. They're in jail. They were convicted of that, and in fact, as I was reading it, they found that they were supposed to, and they even acknowledged in their own paperwork that the drug calculation should have been 425, which is still pretty aggressive.
Yeah.
But he decided, well, on his own, this guy is way out there and being violent and aggressive towards us, so I'm just going to decide to give him all 500. This did not turn out very well for either of them. That being said, when we use these things, especially when we're going to use a dissociative, our patients are not going to be able to tell us a whole lot. Okay? They are relying on us. We are basically turning them into the equivalent of a small child.
Mm-hmm.
Right? Where, like a baby or something, they can look at you and that's about it. And we have to know that we need to manage these patients at that point. We need to have an idea of what to do. So to your point, when you're going to give something like this that might require an airway, have an airway ready.
Yep.
Have a plan B. If you do not have a plan B, then inevitably you're going to need a plan B.
Mm-hmm.
Yeah, you make an interesting point there, Adam, is because when we were talking about analgesics in the last one, we were talking about how pain management is one of the areas we're lacking. I think we see a lot of lawsuits happening as a result of sedatives, and it's because we're running on adrenaline in our fight or flight mode of, oh my gosh, this patient's coming at me, or the cops are yelling at us to take care of it or something, and we know in that moment that we need to do something. Most of the time we are not getting a good assessment. We're not even getting good vitals on them before we're giving them, and we're just giving them to get to the patient to do something, right? And so in 2024, in California, at least 16 people had died over the decade due to a physical medical personnel, EMS in general, giving not ketamine, but midazolam. And what they ended up finding is that it was really honestly happening not just in one area. It was like San Francisco, LA, San Diego, Orange County, San Bernardino, and it was all related to in custody procedures. Instead of tasing the patient from the custody side, paramedics were running in and giving a medication as their force of weapon, which again, sedatives are not meant to kill people. That's not their role. But when we're in these situations where we've got intensity on our back, and then you add in police, and you got people with their cell phones out and everything else that's going on. We live in a world where we take on that scrutiny and we think, oh, I got to act and I got to act now. And sometimes that's not the time or the place. And so the article goes on to say that from 2012 to 2021, a total of 94 deaths involved sedation nationally. That's too many. That's way too many.
Well, the crazy part about this is all 94 could have been avoided.
Absolutely.
You're giving a medication that we use to induce for an airway, right?
Yep.
So the solution...
give them an airway.
...is to give them an airway. And that... it's hard to fathom 94 deaths, and we might see that and say there's 300 million people in America, who cares? But that's from us.
But
we did that.
What do I always say? Anxiety is hypoxia until proven otherwise. So are they anxious because they have an underlying disorder going on? And that's why? And if we fix the airway, we would have fixed the problem. Or are we having the repercussion now as a result? And so it's what came first, the egg or the chicken, right?
Yeah.
So a lot of the medications we're talking about right now, again, we see them more commonly used in our anticonvulsants, which we'll talk about in another podcast. But realistically, as we're preparing to give that respiratory kick that it needs, because we need to take an airway. And so one of the things I like to think about as I'm giving a sedative is if I'm going to induct with Versed or ketamine, then that's what I'm sticking with on my post-sedation management.
Mm-hmm.
And the beautiful part about it is with ketamine, it covers two things, sedation and pain.
Yeah.
Whereas if you induct with Versed, you then have to go ahead and give some kind of pain management with it. And a lot of people fall off that bandwagon of forgetting that. Or, I've got so much time in between, and they don't really. So things to consider in that aspect. Is there anything else you guys could think that you want to talk about in relation to these medications before we close it out?
I got just two things about ketamine. Just why it is, I think, probably going to start coming out ahead on procedural sedations. And I see it all the time in the hospital that it's like 50-50 ketamine or some other drug.
Mm-hmm.
And the reason is that ketamine, it allows for spontaneous respiration post-sedation. So you will not have to run the risk of having to ventilate this patient during a procedure or what have you. They're going to be breathing spontaneously most of the time. So that's a really good benefit in that regard. And it also, for the patients that are having a respiratory issue, it does have some properties to allow it to be a bronchodilator as well for your asthma or COPD patients or what have you. So whenever you are going to choose an induction agent for your breather, maybe think about ketamine, because although we're not giving it for that use, it can benefit them in that regard as well.
Yeah, I realized we just kind of left one off the table, and again, I almost did this earlier, but etomidate.
Yeah.
Etomidate is technically part of our procedural sedation, and technically it's a short-acting hypnotic. So it has a room at the table for sedation, but we see it most commonly in our medicated assisted intubation. We don't really see it when we're going to go cardiovert or pace or put in a joint or realignment or something of that sort. We really just see it in that one aspect. I mean, it was always kind of my go-to when I was going to RSI somebody. It's quick acting, 30 seconds to a minute. It's going to be on board, and then it's going to stay on, but it's short acting as well. So gosh forbid something happens, it's going to be done and out of their system in about 5 to 10 minutes. Mm-hmm. So there's that, but there's not a lot of contraindications with it either. Obviously the typical, I got allergies, but in labor and delivery is the only other one that I'm aware of. And as far as, side effects go compared to all the others, you got a little myoclonic jerking and a little respiratory depression, which, by the way, no offense, we're already dealing with that. We're putting an airway in, so we're going to fix that problem as it is.
It's the whole reason we're doing this.
Right? I think the biggest problem that we have is, where are our large syringes on the ambulance? Because most of the time we're only dealing with 10 ml syringes, maybe a 20, and then we jump up into the 60s when we're talking about having to put in maybe a king airway or some sort. So you're going to have to recruit a larger syringe for this, because we know we're doing the 0.3 milligrams per kilogram. And I was just doing some math, and if I put in a 210 patient and get 95 kilos off that patient, I'm looking at close to 30 milligrams. It was 28 point something milligrams, so I need to find a 30 cc syringe. I will say this is probably that one medication that I do a lot of rounding on. If I was sitting at 28, I'm going to 30. I'm going up a little bit.
Absolutely.
I want to say that this is one of those that I've always been like, we'll just go a smidge.
Yeah, and so as we discuss etomidate a little bit further, I want to bring forward kind of the thinking and ideas behind, like, okay, we have all these other things. Why etomidate? Mm-hmm. Right? So we know that it is a very short acting drug. Okay, and in fact, the NIH says it's an ultra short acting mm-hmm. drug, and because of this, if you start really considering what we're doing, right? So if we're going to use this as an induction agent, a lot of the industry is going away from what we used to just call RSI.
Yep.
Where we would just hit them with not really ketamine, but we would go more etomidate or midazolam, Versed.
I've got all this written up for paralytics.
And then we would just go to paralytics, and then we would get our tube, and we'd move on with life, right? Because then we'd go bang, bang, bang. Here's this, and then we go, right? Well, anymore though, we found that DSI
mm-hmm.
is way better for our patient outcomes. Mm-hmm. And when considering, okay, DSI takes longer. We've gotten rid of the rapid because we now know that we don't need to do that.
Well, yeah, you're sedating the patient to improve oxygenation. I mean, that's the goal, right?
Sure, but if this sedation doesn't last long enough through your DSI, this is not going to be the drug for you.
No.
Now, okay, so then why does it still exist? Let me tell you, this is a fantastic drug for procedural sedation. Mm-hmm. Because it is so short lasting. It is easy to control. You can always give a little bit more. It works very rapidly. It's something that if you just need 5 minutes, to do something or take care of something, this is the way to go.
Yeah.
Right? 5-10 minutes, that's all you need. Etomidate is fantastic.
It's so highly specific that it says that the duration of action is directly correlated to the dose. So for each 0.1 mg per kg that you provide, it'll give 100 seconds of unconsciousness. So you need a specific time, well, drop a specific dose, and there you go.
Absolutely. And Sam was correct too. You know, a lot of people shy away from it. It's an older drug. It's been around forever, but it's been around because, you know, it's almost the short acting ketamine of the sedation world, right?
Yeah.
When we just need a little bit of something, you can reach for etomidate and it's going to work wonderfully.
Yeah, I don't want to touch too much more into the RSI, DSI, DAI because I have it all drafted for Paralytics, where we'll talk a little bit more and bringing those medications into the plactor, especially since we just talked about sedatives. Do y'all have anything else that you want to add into the sedative category before we wrap it up?
I think
we're
we hit
good.
it.
All right. Well, that's a wrap on this episode of the Weatherford College EMS podcast. Big thanks for tuning in as we kicked off this topic of sedation medications, a topic that can feel intimidating, but we promise it gets clearer with every call and every repetition. From Tyler, the NIH man, to Adam, the historian, to myself as the field tester perspective, we're here to guide you through every step of the way. Stay curious, ask questions, and never stop connecting those dots between the meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart. Don't forget, it's not about just knowing the drugs. It's about knowing what they do and why they do it. Have a good day.